Hello friends, my name is Dr. Gaurav Agrawal. I am a pediatric cardiologist working in Delhi. Today I will discuss how do we diagnose and treat tetralogy of Fallot, in short form TOF. In last video we have discussed what is the tetralogy of Fallot and what are the symptoms of tetralogy of Fallot. For diagnosing the tetralogy of Fallot, as I told you in the previous video, we can do fetal echocardiography when the fetus is in the womb of the mother. We can do serial ultrasound imaging from 18 weeks onward till 24 weeks of gestation. By doing ultrasound examination, we can diagnose the tetralogy of Fallot illness, in which there is a big hole between two lower chambers of the heart, along with there is a narrowing or obstruction in the major artery known as pulmonary artery supplying the lungs. If the child is born, how do we diagnose? We can do X-ray chest, in which we can see the boot shape heart. As you can see in this X-ray, the shape of the heart is just like boot shape. We can do ECG also, but ECG sometimes is non-conclusive. So the confirmatory test for diagnosing the tetralogy of Fallot is by doing 2D echocardiography. Sometimes we have to keep the patient quiet. We have to give oral medication so that the child will sleep and we can do the echo quite comfortably. Otherwise the test can be fallacious. So the child should be quiet and comfortable. In rare circumstances, we have to do CT scan of the chest also, CT angiography of the chest, in which if we are not able to size the pulmonary artery on echocardiography, we cannot define the coronary artery on echocardiography, and sometimes we have to see the collaterals that we cannot see on echocardiography. In rare circumstances, we have to do cardiac cath study also. That is invasive test we have to do from the thigh of the baby. After confirming the diagnosis, what is the treatment of this tetralogy of Fallot or TOF? Depending on the symptomatology, if the child is very blue immediately after birth within few days of life, then there are two options available, in which we can increase the blood supply to the lungs so that the pure blood will come to the heart and will supply the body. One option is surgical, known as the BT shunt, in which we have to open from the back. We put a artificial shunt from the major blood vessel of the heart, is known as aorta, to the pulmonary artery. Or another method is by non-surgical method, that is known as the RVOT stenting. We put a stent across the narrowing noted in the pulmonary artery so that the blood supply to the lungs will increase. After any of these, we have to give oral medication in the form of tablet aspirin for few months. After that, we can do the total correction. Total correction means we have to operate the child. Open heart surgery we have to do finally, in which we have to close the hole of the heart along with the removal of the narrowing from the major blood vessel of the lung known as the pulmonary artery. If we have to do the BT shunt initially, then we have to take down this BT shunt, or if we are doing RVOT stenting, then we have to remove the stent at the same time. Parents generally ask, Dr. Saab, can we not treat this without open heart surgery? TOF treatment is only by open heart surgery, that is 100%. We cannot run away by saying that we will not go for surgery. Otherwise what will happen? The bluishness or cyanosis will increase further, the weight gain and the risk to life will increase further. So the parents need not to be panicky, and we have to treat this illness by open heart surgery only. After surgery, we have to keep the child for 5 to 7 days in the hospital, and we can discharge on few medications. We have to follow the child at 1 month, 3 months, 6 months and after 1 year. Then depending on the everything, then we can decide the follow-up at regular interval. Sometimes we have to cut the valve that is present in the major blood vessel of the lung known as the pulmonary artery, known as the pulmonary valve. If this valve is small in size, then we have to cut this valve. If we are cutting this valve at the time of surgery, as we all know that there will be no valve at the same place, so we have to replace the valve at around 15 to 25 years of age. This valve can be replaced either by open heart surgery once again, or by transcatheter or angiographically by going from the thigh. Any of the method can be used depending on the anatomy at that time. For more detail, you can log into my website childrenheartcare.com. Thank you very much.